Good afternoon. My name is Dr. Andrew Vogel. I'm a cardiothoracic surgery resident at the University of North Carolina. I'm here with my attending, Dr. Aurelie Merlo. She is a cardiac attending at the University of North Carolina, and we're here to discuss SAVR versus TAVR. So let's get right into it with the case.
Let's do it.
A 60-year-old male presents with a several-month history of worsening exertional dyspnea, chest pain, and pre-syncopal episodes. His past medical history is notable for coronary artery disease, type 2 diabetes mellitus, and chronic kidney disease stage 1 with a baseline creatinine of 1.3. Transthoracic echocardiography demonstrates the following findings: an aortic valve area of 0.8 centimeters squared, a peak aortic velocity of 5 meters per second, a mean gradient of 60 millimeters of mercury, and they also have aortic insufficiency documented as mild. Their left ventricular ejection fraction is preserved. And ultimately, these findings are consistent with severe high-grade aortic stenosis with concurrent mild degree of aortic insufficiency, representing a mixed aortic valve disease. That patient is referred to a multidisciplinary heart team for evaluation and treatment planning. So when you hear this case presentation for the first time, a 60-year-old male with exertional dyspnea, chest pain, and pre-syncope, as well as these echo numbers, what's your thoughts?
Yeah, I'm pretty worried about him. I'm excited that he's in valve clinic because I'm pretty sure we're going to need to figure out a way to fix his valve, whether it's a transcatheter or open approach. So when I first start talking to him, dive right in, confirm the symptoms, and just get a sense of his surgical risk, ask him about functional status, his comorbidities, and then kind of go from there.
Is there anything else any other imaging or studies that you want to get before walking into our team?
Yeah, when we have people come to our valve clinic, they're already going to get a cardiac CT, protocolized for TAVR, and that includes a chest, abdomen, pelvis CT scan. And the echo, no matter what. And then if we decide to go towards surgery, we might get additional studies like a left heart cath. But I definitely would want at least the echo and the CT scan to make the first sort of big decision of either TAVR or SAVR.
Okay. So let's say we do get the left heart cath.
Okay.
Angiography shows no left main stenosis, but it does show 50% of stenosis of the PDA.
Okay.
The TAVR CT shows no concerns for catheter placement and TAVR placement. His STS risk is an operative mortality of 0.82% and a morbidity mortality of 5% roughly.
Okay.
So he's 60 years old with what seems like a low surgical profile. How do you think the current guidelines correspond with how to frame this decision for the patient?
Yeah, I think a low-risk surgical patient, we should be offering surgical AVR. And go over sort of risk benefits of that with them. And then in practice, the sort of structural heart team would also be meeting him and determining what's his risk of TAVR. If he has no sort of anatomical risk factors and he's low risk for TAVR, then we would be talking about probably both options and recommending sort of surgery over TAVR.
Okay. Well, so let's say that we're going to give our case for SAVR.
Okay.
What would you tell this patient?
The biggest thing is that he's young. This guy's going to need sort of a valve that either lasts his whole life or a valve strategy that lasts his whole life. And we have really good data with mechanical valves, of course, but also just understanding the longevity of surgical tissue valves. We know how long they last. We know when they deteriorate. And we just don't have that for TAVR valves yet. And so that's sort of the biggest peace of mind. Mm-hmm. Also, we can talk about slightly lower pacemaker rates with surgical AVR. But I think the big thing is sort of longevity and lifelong strategy of the aortic valve, management of aortic valve disease.
Okay. Thank you for that. Now let's say we change it up, and how do we make the case for TAVR?
Okay, so we see a lot of patients like this, and they might say oh, I have this really huge life thing going on, and I just can't be out of work for a month, or I'm taking care of my debilitated parent or wife or spouse, whatever. And so definitely the recovery period is so much faster for TAVR. There's also real risks, though, that are improved with TAVR. So the perioperative risks of things like stroke and mortality are definitely lower in the short term for TAVR than for surgical AVR. And that's not something that we should just ignore. It's important to talk to patients about those perioperative risks.
Okay. So let's say after all this discussion, we ultimately land on SAVR.
Okay.
Now the major decision comes down between, are we going to do a mechanical valve or are we going to do a bioprosthetic valve? How do you approach that with the patient?
Yeah, so he's 60, I think you said.
Yes.
He's really in a gray zone. And so, in someone who's under 50, I really sort of come on strong with recommending a mechanical valve if possible. And someone who's over 70, I kind of say it's a no-brainer, we should do a tissue valve for you. And then someone in between 50 and 70, there's a lot of things to think about. One thing is, are they on a blood thinner already? Are they already on Coumadin? Of course, in that case, it might make sense to do something like a mechanical valve. Understanding sort of their lifestyle, their risks of bleeding. Have they had previous bleeding episodes? Do they have AFib? Things like that. And then just explaining to them what it's like to have a mechanical valve versus a tissue valve. So, as we all know, with a mechanical valve, you have to take Coumadin, sort of lab draws, and now there's home monitors, but sort of how that impacts your life, dietary restrictions, etc. There are newer valves that have slightly lower INR goals, but still you have to be on Coumadin. With the tissue valve, you can be on an aspirin, baby aspirin only. That's really good. I sort of say that to the patient, but say the downside is the valve ages. And so it may only last 10, 15 years. And we have to make sure that we have a good strategy for what to do when the valve fails. With tissue valves, we can do valve and valve TAVR, and so that can be a really good option for people. But it's important to think about things like the annulus size and sort of how young they are, their life expectancy, how many valves are we going to be able to do for them.
Thank you. So when approaching the heart team, how does that discussion look when talking about a patient? Like, how do you correspond with or talk with the interventional cardiologist, and how do you have that discussion to kind of, hey, I think this patient is probably better for SAVR?
Yeah, I think we're lucky here. We have a truly multidisciplinary clinic, and it's very collaborative. Sort of both of us, surgery and cardiology, will go and see the patient and sort of form our independent assessment of risk or whatever. And then usually we sort of chat in the background and say like, hey, I was thinking surgery for this person, or hey, I was thinking TAVR. And sometimes the other person sort of notes something that I didn't see, or I point out something that they didn't see, like, oh, this patient doesn't accept blood products, or oh, this patient has a really low coronary height, like maybe the TAVR would be higher risk. So we sort of like share notes and come up with a plan together, and then share that plan with the patient and say like, hey, this is sort of our best recommendation for you, and here's why.
Okay. As a resident, trying to learn all these different things, what are some key things that you would take away from, like, for example, a consult for an aortic valve replacement?
Yeah, I think the first thing is knowing, it starts with just having the book knowledge. So you want to know the classification for mild, moderate, and aortic stenosis. We see a lot of patients in valve clinic that have moderate aortic stenosis, and we plan to monitor them. So that's one thing. The second thing is understanding sort of more nuanced concepts like low flow, low gradient aortic stenosis, and knowing that you may need to sort of induce the aortic stenosis if they have a reduced ejection fraction, like with the dobutamine stress echo. The third thing is understanding the nuances of sort of the options, and sort of putting the patient shared decision making at the forefront of how you consult patients. Like they should be involved and have all the information possible, but also like you have to know the guidelines and the recommendations. So like if a patient really wants a tissue valve and they're 45, of course like you should still probably do that if they refuse the other one, but you really need to advise them about the risks and benefits of that. Mm-hmm. And then lastly, I think the best thing for patient care is to use a multidisciplinary approach and do heart team. It's more eyes on the patient, really thinking about the different approaches, the pros and cons of different therapies, and really the best care for a patient is multidisciplinary, and we're lucky to have that here.
Yeah. Okay. Well, Dr. Merlo, I can't thank you enough. That was an outstanding summary of SAVR versus TAVR. I'm sure the association would be really happy to hear this conversation, so thank you so much.
Thank you. It was my pleasure. It was fun. Thanks.